Well, good evening, friends and supporters, and welcome to this September edition of our live Q&A, proudly brought to you by our long-standing and very generous supporters at Glaucos. My name is Adam Check, and on behalf of Glaucoma Australia and our family, it's great to have you with us for this particularly exciting event. Now, before I introduce your guest speaker this evening, I would like to take a moment to acknowledge the traditional custodians of the lands, the skies, and the seas in which we collectively gather for tonight's event. I'm currently on Dharawal country, and so I pay my respects to those elders past and present, along with their emerging leaders. Now, tonight we're very fortunate to have Professor Jonathan Crowston, a great mentor, a wonderful friend of Glaucoma Australia, and a passionate advocate for the glaucoma community, to talk through neuroprotection in glaucoma, the needs, the challenges, and the advances that Jonathan has very much spearheaded. Jonathan is an ophthalmologist and clinician-scientist. He's the appointed Professor of Ophthalmology at Sydney University and glaucoma consultant at RPA Hospital. Previously, he led the Centre for Vision Research at Duke NUS Singapore, and prior to that was the Ringland Anderson Professor of Ophthalmology and the Director of Centre for Eye Research Australia. Jonathan has authored over 230 publications and co-edited a major textbook in glaucoma. He's contributed to securing over $120 million in competitive and philanthropic research funding and received a number of national and international awards for research, for mentorship, and for education. Recently, Jonathan was awarded a $50 million funding grant from the Snow Medical Research Foundation to establish the Snow Vision Accelerator and to develop novel treatments that protect the optic nerve in glaucoma. But most importantly, he is an all-round good guy and always available to support Glaucoma Australia and, of course, our passionate patient family. So, Professor Crowston, welcome, and the floor is all yours.
Adam, thank you for the overly generous introduction, and also to you and Glaucoma Australia for really having another fantastic education event. And I hope I can live up to that introduction. But if I can start off with my slides, I'd be keen to start off with a sort of 20-minute presentation as to where we are with respect to developing new treatments for glaucoma. So Adam's already read the title out for you. I'm not going to repeat that. But what I'm going to start off is fairly basic and just remind everyone of what glaucoma is. It's a disease of the optic nerve head. And here you see an optic nerve head. It's actually my left optic nerve head. And this is the part of the eye where the axons, the cables of the nerve cells that transmit the visual message from the eye to the brain, take a 90-degree turn. I don't know if you can see my mouse, but the little yellow cells on the inside of the retina on the cross-section there have long cables that feed back to the brain. And it's this area here at the optic nerve head where we believe the damage occurs to these nerve cells that ultimately causes glaucoma. When we as clinicians look at glaucoma patients, what we're looking for are changes to the structure and the function of the optic nerve. The top left-hand side here, you see a healthy optic nerve with a nice, thick, dark pink rim, which in the right top figure there you can see has thinned dramatically, and this is what we see as clinicians when we look into the back of the eye in glaucoma. And this loss of nerve cells, a progressive loss of nerve cells, leads to a progressive loss of peripheral, mid-peripheral vision, and the classic visual field defects in glaucoma. The cells in the middle here are the cells that die off in glaucoma. This is the retinal ganglion cell. This is the intraretinal portion. These are big cells with dendrites, which are these branches. They look like branches of a tree, which connect to the cells that activate them in the mid-retina. And the bottom green figure there is actually a mouse retina, and this is a genetically modified mouse where these retinal ganglion cells that die in glaucoma are made to fluoresce. So you can see the cell bodies, which are the little dots, and the lines, which are the cables, the axons that send the message back to the brain. We know a lot about glaucoma and what causes glaucoma. We know that there's some significant risk factors, and elevated eye pressure and advancing age, as well as family history, are really the leading risk factors for the disease. And the third one I always emphasize, because that's something that we should all know about, and we should always, if we have glaucoma, alert our first degree relatives and make sure they get their eyes checked. So just a quick plug for that. We're good at treating glaucoma, but there are two major gaps in our ability to treat this disease. The first is that treatments are limited to the lowering of eye pressure. We have medical treatments, laser and surgery, and all of these target eye pressure lowering. And we've conducted many high quality clinical trials, all of which show that if you treat eye pressure, lower eye pressure, that you can slow down the rate of progression. The EMGT study that you're seeing in the bottom left there is one such example. The black line represents the number of patients who progressed off treatment, the gray line, the number of patients who progressed on treatment. And you can see there's a slowing in the rates or the numbers of people who progressed. But even with treatment, people are still progressing. And so we need further treatments that help to actually stop glaucoma progression. And that's where I'm going to come to later in this talk. A second area, which I'm not going to talk on in this talk for time's sake, is that currently once we've lost nerve or the nerve has become irreversible damage, we cannot restore vision. This is not the case in all animals. And on the top right there, you see a picture of a Xenopus larva. These are African clawed frogs. And if you cut the nerve of an African clawed frog, at any stage during its lifetime, it's able to fully reconstitute its optic nerve and regain its vision. And, glaucoma would not be a problem if we large mammals were able to do the same. Unfortunately, mammals cannot regenerate their optic nerves, although there are treatments that can at least start this process. And then the bottom panels there, the red panels, you see an optic nerve in a rat that's been cut, and it's been encouraged to regrow using a number of different treatments. And although we can get the axons to regrow, we can't get them to regrow in a really accurate way back to the brain. So regeneration still has a way to go, but there's a lot of really good active research currently ongoing, and I'm hopeful that in the coming decades, this may be something that we can actually use in as a treatment. So this talk is going to talk about the first treatment gap, and that is to look at whether it's possible to develop treatments that actually directly protect the optic nerve. And these would complement treatments that lower intraocular pressure. And how might we do that? Well, as I mentioned a few slides ago, the other major risk factor for glaucoma that's been largely ignored is advancing age. And on this graph here, you see the outputs of a lot of population-based studies from a lot of different populations. And in almost every study, there's this non-linear increase in the rates of glaucoma with increasing age. And this is something that is extremely well known, but has largely been ignored because we've generally perceived that you can't do anything about the aging process. And I'm about to tell you that that's actually not true. This is more recent data from Felipe Medeiros now in Miami, in Florida. And it's a really beautiful piece of work, which looked at 7,000 glaucoma patients. And it looked at the rates of optic nerve thinning with different levels of average intraocular pressure. And the lines, the three lines that you can see there, the green, the blue, and the red, all relate to patients of different ages. And what it shows you is that in patients who are the oldest in their 80s, that at every level of intraocular pressures, the rates at which their nerves got thinner was greater than patients who are less old or the youngest patients. And this suggested that with advancing age in humans, that there's this loss of resilience, that the optic nerve becomes more susceptible to every level of eye pressure. And this backs up work that we've done prior to this in rodents, which I'm not going to show you tonight, which again shows exactly the same thing. That as rodents get older, it's much easier to damage their optic nerves by raising by raising the eye pressure. So, of course, the key question then is, well, can we do something about this? Are we able to reverse this age-related loss of nerve resilience? And the answer is that, yes, we probably can. And this is consequent to a large body of work that's come up in the last 2 decades, which has really helped us understand the biological processes by which our cells and our bodies age. And there are many approaches now that have been investigated, some in very high quality science, some perhaps less quality science, but I'll show you a couple of examples here. One of the landmark studies came out of Chicago by Richard Coleman, and this was a study in monkeys where they took monkeys, I believe around age of 6 years, and they randomized them to either having a normal diet, and that's the panel on the left-hand side, or a diet that had 20% less calories in their daily diet. And what they found was that the animals, the monkeys that had this diet restriction aged much more slowly. They lived longer and they got much less in the way of age-associated diseases. And you can see very clearly here, these animals are exactly the same age, but the one on the left looks a lot older than the one on the right. I have to say the one on the right looks quite angry, and so probably isn't very happy about the diet restriction. And this kind of reminds us that diet restriction probably isn't a treatment that's amenable to many of our patients. There are much more specific approaches, and here's a very recent one that was published in Nature, a very prominent journal last year, where mice were treated with an inhibitor of an inflammatory factor. And you can see the mice that received this treatment aged much more slowly and lived longer and got less in the way of age-related disease. And we've become very interested in some of these processes by which our optic nerves age, and this really focuses around mitochondria, the energy-producing organelles within our cells, and metabolic dysfunction. I'm not going to go into this in any detail. I don't think it's necessary for today's talk, but all the segments in that pie chart on the right hand side are approaches that people are taking to slowing down the aging process. Now, how might we target aging in glaucoma? Is there any evidence that this can be done? And the answer to that is yes, there's preliminary evidence. And the words in orange there are probably where there's the most robust evidence. We've certainly shown that if you're a mouse and you're subject to exercise, that you can make the optic nerves much more robust and resilient to intraocular pressure elevation. There's some population-based data that suggests that diet can also have an impact, and perhaps this is something we could discuss if there's time in the Q&A. But certain diets are thought to be helpful. Avoiding excess alcohol may also be helpful. These are all weak effects, but certainly can impact the rates of progression of disease. There are also specific therapeutic targets that have been tested, largely in small studies. The most robust evidence is, of course, if you lower the eye pressure, you protect the optic nerve. We know that very well, but really here focusing on treatments that target the optic nerve. Now, why do we have treatments that lower eye pressure but don't directly protect the optic nerve? And the answer to that is largely around the cost of doing these studies. To measure the response to an eye pressure lowering drop or laser or operation, you don't need to follow the patients very long. Most eye drop studies would last about 3 months, where you treat somebody and then look at the effect. If you're looking at optic nerve directed treatments, we know the studies have to be much, much larger and are therefore much more expensive. And this is some really nice work that was conducted out of London about 10 years ago and published in the Lancet, where they showed for the first time that using these improved diagnostic instruments that we now have, we can reduce the length of time it would take to do a study to look at an optic nerve directed treatment down to around about 12 to 24 months. And we've currently got studies that are of that duration. Prior to that, the only large nerve treatment that has been studied was the memantine study, which was done 25 years ago. And they followed patients in that study for 7 years. And sadly, it didn't reach its primary endpoint. So the treatment did not prove to be sufficiently effective. And that was an extraordinarily expensive study to follow a large number of patients over such a long period of time. So where can we start? A paper came out in 2017 that really is a landmark study, and these are the two authors, Pete Williams and Simon John, who were then in the JAX labs in the east coast of the USA, and they looked at a treatment related to vitamin B3 called nicotinamide, and they showed that mice that inherit glaucoma are robustly protected by giving them nicotinamide either in their diet or in their drinking water or with a gene therapy approach. And this study, and I'm not going to go through any of the data, it's not relevant here, but this study, I think, provided very robust scientific evidence that nicotinamide could protect the optic nerve. Now, what is nicotinamide? As I mentioned, it's a precursor of vitamin B3. It's present in certain dietary ingredients in lean meat, fish, nuts, legumes, and most multivitamins have low doses of vitamin B3. In our habitual diet, we only need about 15 to 20 milligrams a day. It's available at much higher doses, as available without a prescription in health food stores. And it's been used really for the treatment of cholesterol. There's very good evidence. Again, a further study came out very recently on skin cancer prevention, and a lot of dermatologists are now prescribing it to reduce skin cancer risk in and across Australia. And there's some 600 clinical trials now looking at nicotinamide in a number of different different diseases. And so with that rodent data and the knowledge that this is a cheap and fairly accessible treatment, we and others have looked at a number of other experimental models for glaucoma, and most of them, not all, but most of them have shown very robust protection, showing that the optic nerve is made much more resilient to various injuries if you supplement the diet of mice or rats with nicotinamide. We were very encouraged by this and did the first pilot study in humans. This was a small study with 57 patients where we looked at the effect of nicotinamide treatment on short-term changes in optic nerve function, and showed that nicotinamide very subtly but significantly improved retinal ganglion cell function in patients whilst they were taking nicotinamide. And we compared these patients at different time points to when they were taking nicotinamide or when they were taking a sugar placebo control. A second study came out of the US more recently, again a small study, also showing an improvement in visual field in patients who were randomized to taking nicotinamide versus a sugar placebo. And this has led now to a fair bit of interest across glaucoma, and we're now involved with 4 large randomized controlled trials. And you can see the steering panel down here, which includes Pete and Simon, who are the original discoverers of nicotinamide as a treatment, Bob Caston and Keith Martin, some of you may know, some leading lights in glaucoma research. And we're now well into these studies. We've recruited some 700 patients so far, and there's a 2-year follow-up, and we're hoping that these studies will come out in the next couple of years. Unfortunately, again, as I said before, these are not quick studies, but we're hopeful that we can at least know whether or not nicotinamide protects in the long term. We've shown it does in the short term, but we don't know about the long term. Now, before everybody rushes out and goes to the health store and buys vitamin B3 tablets, a word of caution: I wouldn't encourage anybody to take it really at high doses that we're using in the clinical trials outside of a clinical trial. And the reason for this is that, and I give a talk called The Good, the Bad, and the Ugly, is that although it's very promising as a potential protectant for glaucoma, it can activate in certain patient groups, we believe it can activate some byproducts that may actually lead to nerve degeneration. So may actually in some patient groups have the opposite effect of what we want, which is to protect the optic nerve. And then finally, we've seen at least 2 significant adverse events in patients taking nicotinamide. And one of these was in the US, the other one was in Singapore. And these were patients who actually developed liver function problems with their liver function. The American patient actually went into temporary liver failure, which rapidly reversed when they stopped the active ingredient, but still, doing this in an unsupervised treatment paradigm is definitely not to be encouraged. So we need better ways of developing treatments that protect the optic nerve. And this leads us to some really exciting funding that we've recently received, as Adam said, from the Snow Medical Research Foundation. And I'd just like to acknowledge Terry and Tom Snow on the left-hand side there, who really are making a big difference in not only glaucoma research, but have funded over $250 million worth of biomedical research in Australia. On the right-hand side, you see some Snow Fellows. These are some of Australia's brightest biomedical researchers who are all working in different fields. Owen Siggs on the very prominent front of that picture on the front right-hand side is working on glaucoma genetics. So the Snow families have been really good to funding glaucoma research. So what is the Snow Vision Accelerator, as we call this program? It's a $50 million program that is really aiming to develop new drugs to increase the resilience of the optic nerve to glaucoma. And really there are 3 goals. 1 is to develop drugs, 2 is to train the next generation of outstanding glaucoma researchers, and thirdly, to grow the accelerator into a leading product-focused optic nerve research program. And the cartoon on the right-hand side really shows what it's about. It's about reversing this age-related loss of neuronal resilience that I've already mentioned to you. This is a cartoon. We've got 4 parts of this program: a biology and bioinformatics part, which is really to discover new pathways that can be targeted with small molecules or biologics, and these working together with a really talented group down at Monash University, the School of Pharmacy down there, who've got really strong track record in developing new drugs. They're going to be working with our biologists and our bioinformaticians to develop new candidates to take them through to the stage that we can then put them back into our clinical program that we're developing. I'll tell you a little bit more about that clinical program because some of you may be interested in joining us with this. We're building an outstanding team of researchers, biomedical researchers, as well as clinicians, and also in the bottom right there, 2 of Australia's leading drug developers. And this is not just an Australian approach. The Australians are leading it, but really there's an international approach with some really talented American researchers in the bottom left who are providing us with some access to primate work, and top right, some really talented Europeans who are also really helping to guide this project. We've also got some fantastic Australian researchers on the right hand side there, and hopefully some of them joining us on this call. So the 4 platforms, I'm not going to go into any major detail because of time, but essentially this is targeting the metabolic and mitochondrial changes that are known to occur with aging to find new pathways. We're working with bioinformaticians to really identify which ones are the most likely to impact the rate of disease. And as I mentioned, we're going down to MIPS, where essentially the design of the small molecules and the biologics will take place, and this will then be translated. It's a 4 to 5 year journey before we've got candidates that we can put back into our patients. This is the clinical program, and really a key part of this. And Rudy Lim, who's head of glaucoma at the Eye Hospital in Sydney, and Katrina Bell, who's a colleague here in the CPC, will be leading this 1,000 patient cohort, who will be deep phenotyped and followed for 5 years. And when the time comes that we have new candidates, they'll be the first people who have access to some of these new treatments, we hope. And if anybody who's on the call who's interested in being part of this program, you'll be seen for every 6 months for 5 years. Please get in touch with Glaucoma Australia, and we'll see whether we can add you to a list to be included in this. We're also doing some work on clinical trial design because we want to make these trials cheaper and quicker. And also we're very keen to work on equity. Kat Bell's done some work where she's shown that really, unless you're living within a metropolitan centre in Sydney, it's very difficult to participate in clinical trials in ophthalmology. And this is something that we're, with home monitoring and other techniques, we're looking to improve. So in summary, we're looking at developing treatments that improve the resilience of the optic nerve. And these will complement eye pressure lowering treatment. So this is not instead of eye pressure lowering, but hopefully it will offset the need to get down to really low pressures to stop the disease from progressing. Developing such treatments is challenging, much more challenging than eye pressure lowering because of the time and the cost. But I believe with recent developments in the way we conduct clinical trials that this is now much more feasible, and we're showing this is the case with proof in principle with the nicotinamide study. And the Snow Vision Accelerator really is a bold new research program that aims to develop exactly such treatments that we hope will transform the way that we're able to treat glaucoma in the future. So with that, thank you for your attention. I'm sorry I went on for 2 or 3 minutes longer than I'd hoped to, but I'm very happy to answer questions. So Adam, back to you.
Well, thank you, Jonathan. And again, I think we need to recognise not only the Snow family and that wonderful group of people, but also you and your credibility in being able to unlock that partnership and that funding. And we, the Glaucoma Australia body, and of course all of our patient and supporter community, will be behind you on your journey as you go forth. So thank you for making your time, and as always, your wonderful insights. Now, the Q&A chat box has lit up, so not surprising. So maybe a couple of questions. The first one is from one of our supporters, David, and it is, I've heard that a growth factor had been discovered at a US university, possibly Princeton, which causes regeneration of retinal cells without tumour formation. If that's true, what are the implications for glaucoma treatment?
Yeah, look, I think this is regeneration. This is the part that I didn't address because of time, and this is something that I think needs funding, and there's a number of groups, particularly in the US, but also in Australia, that are addressing this, and that is to regrow an optic nerve once it's been damaged. Currently, when you've lost your optic nerve, we can't restore that. I think the work this is referring to is actually work from Harvard, from David Sinclair's group, where they essentially used a number of regeneration factors that were initially discovered by Yamanaka, who developed the way that we can generate stem cells. And what they did was they reprogrammed cells in the retinas of rodents, and were able to initiate some regeneration and restoration of vision by reversing the biological markers of aging, interestingly. So this is very exciting work. It's been done in that one paper that was published, I believe, in Nature a couple of years back. But I think is heading in absolutely the right direction. I think this, more work is clearly needed, but this is very exciting that it is possible to regenerate an optic nerve in a mammal if you can unlock certain pathways that normally prevent the mammalian optic nerve from regenerating.
Fantastic. Thank you, Jonathan. Another question from Linda, one of our supporters, and it's in reference to the nicotinamide trial. So it's believed that the trials used a higher dosage of nicotinamide, and what would be an appropriate dose for someone who has suffered vision loss already?
Yeah, look, it's a really good question, and I'm sorry I can't give you an informed answer to that. Now, so in the clinical trials, we're looking at 3 grams a day. That's a very high dose. So as I mentioned earlier, that the daily requirement for vitamin B3 is about 15 milligrams. So we're using, 100-fold increase than what is actually normally in the diet. And the reason for that is the sort of the comparative dose that we used in some of the rodent studies, and then sort of worked out the mass of the relative organisms, and then worked out that we need really quite high doses. We're using those high doses in the clinical trials. As I mentioned, that needs to be done under medical monitoring, because even though these are supplements at such high levels, these supplements can be toxic. And some of you may be aware that the FDA has recently removed vitamin B6, a different vitamin B, from the shelves, from health food stores, because of complications. And so when patients ask me, and if they're very keen to take vitamin B3, I recommend either 500 milligrams or 1 gram. And the rationale for that is that that's been shown very well to reduce our risk of skin cancer. And of course, Australians are 4 times, I think, 4 times more likely to get skin cancer than people in the Europeans in other countries. Yeah, and so because of our increased skin cancer risk, I think that's reasonable to take that amount of vitamin B3. It may help your glaucoma as well. We haven't got robust evidence for that. We think and we hope that it will help, but we still need to wait for these clinical studies before I think it's fair for us to be recommending these high doses. Now, in the Singapore study, because of a number of side effects that our patients were getting at 3 grams, we've tailed that study back to 1.5 grams. So that's just a bit higher than what is in the skin cancer studies. But I'd be going 500 milligrams, possibly 1 gram, but certainly not higher than that at the moment. But again, echoing the fact that we really need that evidence to show that it slows long-term progression.
Okay. Well, Jonathan, while I was starting to navigate myself around a calorie-reduced diet for my own needs, we have now a very technical question from another one of our supporters, Janice, which was, is there any current research in treating optic nerve drusen?
Yeah, that's a great question. So optic nerve drusen is different to glaucoma, and these are little sort of formations that occur deep in the optic nerve head, relating to calcium, and it's probably genetically induced. But what's interesting is it occurs at the damage occurs at the same location, or very similar location to where glaucoma damage occurs. And we think that mechanical strain or stress on the axons of these retinal ganglion cells is what happens in glaucoma when the eye pressure is elevated. And these optic nerve drusen, these deposits that occur in the optic nerve, may also induce mechanical stress on retinal ganglion cells. And so one of the treatments that I've been prescribing to some, and I don't have a large number of drusen patients, but I do tend to lower their eye pressure. Their eye pressure is high. There's no evidence. There's one study that looked at about 30 patients that showed some slowing of progression, but that really wasn't a large enough study to be conclusive. But it's on the hypothesis that if you can lower the eye pressure, you may be reducing some of the mechanical stress on those axons. But so far, unfortunately, there's no proven treatment for the treatment of drusen, but lowering eye pressure, if you're going to do anything, may be something that could help.
Thanks, Jonathan. And a great question here from Edward, and it's more related or based around glaucoma and children, which is, of course, less prevalent. but it's, do you think potential treatments such as nicotinamide and neuroprotectants will be applicable to children who've got glaucoma as well?
Yeah, absolutely. And going back to those aging graphs I showed you, children hopefully have more robust optic nerves, and when children present with glaucoma, often they present with extremely high pressures, and so children may already have fairly resilient optic nerves. And so the prime mode of treatment now for children born with glaucoma or with developing glaucoma in the first few years of life is surgical, because they run very high pressures and they need that pressure lowering. Fortunately, if they have resilient nerves, nicotinamide may not be necessary. But I think that in some cases it's difficult to get the pressure down to the levels you want to, and in such patients it may well be that these ancillary neuroprotective treatments are of value. When you develop drugs, you initially develop them in adults and then test to see whether they're safe in children. So this is something that'll hopefully happen down the road. But the mainstay of childhood glaucoma treatment is still lowering of intraocular pressure.
Okay, terrific. And maybe one final question for this live Q&A, and we have got a number of questions which, by you, Jonathan, and of course our orthoptic educators we will answer. But the last one is, are there supplements that you recommend beside nicotinamide?
Yeah, one of the challenges is, as I mentioned, that these testing these drugs to the level that we need in order to be able to prescribe them or really strongly recommend them, is that you need, at the moment, 500, 600, 700 patients, treating somebody over 2 years. None of these supplements have been subject to that level of scrutiny. And so there are things like ginkgo biloba, CoQ10, resveratrol, a number of treatments that some clinicians are recommending, but we really don't have the evidence to support that. And what I'm hoping is that as this program, the SNOW program, and other advances occur in the way that we monitor disease, that we're able now to reduce the time and the cost, such that these supplements and other new treatments can be tested. So I'm really hopeful that things are changing in glaucoma, and what was perceived as being in the too hard basket is now possible, and that in the coming decade or so we're going to be having lots of studies that are really investigating and hopefully allowing us to give a much better answer to the one I'm already giving, as to whether these agents are helpful.
Thank you, Jonathan. We have a number of other questions, of course, from our patient community and supporters, but we might leave it there. I think most importantly, we're going to keep our patient community updated with your work and your advancements. And again, congratulations on everything you've achieved so far, and of course, your upcoming trials. We will, for our patient community, answer all of those questions that you've sent through across our various channels in due course. Okay. We will upload this presentation as well, so you can make that available to your friends and to your own community. And of course, for first-degree relatives, we firmly encourage getting yourself checked and consulting with your practitioner. But for now, Jonathan, thank you for your time.
Thank you, Adam. And if I could just very quickly just thank the patients who, not only for listening tonight, but also for all the patients who've been involved in glaucoma research. And we're very much hoping that we can open up access for people who are interested in participating in research. You're really performing a very important function that is allowing us to provide the answers to some of the questions that I've been trying to answer. So thank you to everyone who's been involved.
You're a good man. Well, that's going to conclude our live Q&A tonight for September. And very much, again, Jonathan, thank you so much for your time and your passion as always. And to our patient community, thank you for your ongoing support. And of course, we will stay connected as always. And for now, a good evening to everybody.
Thank you, Adam.